So we stopped at this topic, that is pramipexole. It is a non-ergot derivative of dopamine agonist. It binds to presynaptic and postsynaptic D2 and D3 receptors. Mechanism is same as agonist, so it acts on D2 and receptors. It is used as a monotherapy in early Parkinsonism, and also it is used along with levodopa in advanced stages of Parkinsonism. Side effects are it causes nausea, dizziness, constipation, and when advanced disease, most common adverse effect is orthostatic hypotension. It has got drug interaction with so many drugs. Then we started with MAO inhibitors yesterday. That is, there are two types of isoenzymes are there. That is MAO A and MAO B. Out of that, MAO B is responsible for the oxidative metabolism. We have seen that it is converted so these are the activities. The MAO B inhibitors we therefore use because their oxidative metabolism in the brain can be decreased. There are various drugs in that. That is selegiline is one of that. It is selectively irreversible inhibitor of MAO B. It prolongs the T-off of endogenously produced dopamine. Anti-Parkinsonism effect of dopamine, it increases. It reduces the on-off wearing of phenomena with that. And we have seen how it is acting. That is, these are the drugs in CNS. That is selegiline, rasagiline. These are the drugs which are MAO inhibitors. This figure we have seen earlier also. That is how metabolism takes place. When we give L-dopa, then L-dopa is metabolized in periphery in two ways. That is, one through COMT, one is through this enzyme, that is, which causes dopa decarboxylase, and this dopa decarboxylase causes convert into dopamine. That is, but we do not want into periphery, so we make this peripheral dopa decarboxylase blocker, that is carbidopa, so that maximum levodopa can be absorbed, and here again it is converted into this dopamine. This is, once this dopamine is formed, is metabolized into by two enzymes. One is monoamino oxidase, particularly B, and the catechol-O-methyltransferase. This all enzyme, as I told you yesterday, that this you have studied all these enzymes during your adrenergic mechanism, because how the adrenergic system are working and they are getting metabolized. So next drug in that are mechanism is it reduces the breakdown of dopamine in CNS through MAO. It causes the blockages of presynaptic dopamine receptor. It inhibits the dopamine reuptake from the synapse. It is extensively metabolized in the liver. Metabolites are the desmethylselegiline and methamphetamine. This is another problem because they are converted into amphetamine, and this amphetamine has got so many central nervous system problems. Amphetamine, if you remember, amphetamine we have studied as a indirectly acting adrenergic agent. If you have not, you can go through it, you can study it. So here this is the adrenergic agent, and it causes CNS stimulation. It is used for various abuse purposes and many other activity it has got. So this is the drug that is desmethylselegiline and methamphetamine. That is, and therefore it will cause various activities like confusion, psychosis, and postural hypotension. All of these drugs will cause postural hypotension if you see. Then next drug are COMT. Yes, another drug in that. Sorry. So there are various interaction with tricyclic. Selegiline is having interaction with tricyclic antidepressant with pethidine. It causes excitement and rigidity when it is given. Selegiline also is having interaction with selective serotonin reuptake inhibitors, that is, they are used in the depression, and they are contraindicated in the patient with convulsive disorders. Rasagiline is a newer analog of it, that it is a newer selective MAO-B inhibitor. It is 5 times more potent than selegiline. It is longer acting. It is not metabolized to amphetamine. That is the benefit, and therefore it is beneficial. It does not produce any excitatory side effects. COMT inhibitors are the next class of drugs. Example of these are entacapone and tolcapone. Again, we have seen this, that these drugs have these enzymes are present in periphery also and in CNS also. So tolcapone can cross blood-brain barrier, while entacapone only prevents the peripheral one. Tolcapone can prevent both, that is, in periphery also, and it will prevent in the CNS also, and thus it is beneficial for both. So tolcapone is preferred over entacapone because it can do comparatively more blockages of metabolism. So entacapone is a reversible COMT inhibitor. Entacapone has only peripheral action. It is selective and reversible inhibitor of catechol-O-methyl transferase enzyme. Its adverse effects are dyskinesia, nausea, diarrhea, abdominal pain, urinary discoloration, and it increases the side effects of the levodopa, is the problem. Tolcapone is better, selective and reversible inhibitor. It has got peripheral as well as central action. Occasionally it is associated with the hepatotoxicity, and therefore when this drug is administered, the liver function test should be done, because again Parkinsonism needs the continuous treatment for long period, and when you want to save the person from Parkinsonism, it should not happen that person has got liver problem. Particularly we know that this is happening in the older ages, and therefore that care has to be taken. Then other agents in that are dopamine based. Other drugs are like dopamine facilitators. Example of these are amantadine. The mechanism of action is it acts presynaptically, it is and also postsynaptically. It causes release of storage catecholamines from the intact dopaminergic terminals. It inhibits the catecholamine reuptake process at the presynaptic terminal. Then next drugs in that classes are the actions are it causes activation of dopamine receptor directly, anticholinergic actions. It shows NMDA receptor blocking effect. If you remember earlier, we have seen the pathways. We have seen that what happens, that is, when there is a less dopamine, then cholinergic activity increases, and we want to reduce it. We otherwise administer anticholinergic agent, and we have also seen that through glutamate receptors, the final messages are carried to the cerebral cortex. So if we have this agent, it can have all these activities simultaneously. It activates dopamine, it blocks choline as acetylcholine, and it also blocks the NMDA receptor. So it has got various effect, but because of adverse effect, it can be only used in the milder cases as a monotherapy, and that too it is used in what condition where L-dopa is not used. It has got a problem because L-dopa otherwise is safer and better than other drugs. It is supplement to levodopa for advanced cases. It is used as it is served as suppress motor fluctuations and abnormal movements. Side effects are insomnia, dizziness, confusion, nightmares. These are various adverse effects it has got. Then the next class of drugs, central anticholinergic. Now again, this I emphasized earlier that this type of drugs basically we teach in pharmacology, but we will not find them in therapeutics. The reason is they have got less therapeutic benefits as compared to all other drugs which are acting on dopaminergic pathway, and therefore they are of just what we can say pharmacology interest, that these are also drugs, or this drug can be added into the treatment when the dopaminergic treatment has got a problem. So they are the only drug effective in drug-induced Parkinsonism, because in drug-induced Parkinsonism, the problem is it is because of the dopamine blockers are there, in that it is there. And in that cases, these are having problem. These are antimuscarinic agents. They improve the tremor and rigidity, but they have little effect on the bradykinesia. So they are useful in the iatrogenic. This is a word which you may encounter many times. Iatrogenic means acquired in during treatment, or we call it as a hospital acquired. So it can be, it is part of iatrogenic Parkinsonism, particularly because of antidopaminergic drug. We have seen earlier there are so many antidopaminergic drugs, and very commonly used are the antipsychotics, that is typical antipsychotics, which are antidopaminergic agent, and these are responsible for, we call it as a EPS, that is extrapyramidal symptoms. So that is what we call as a iatrogenic. Why iatrogenic? Because of the treatment the person has got Parkinsonism, so we call it as a iatrogenic one. Then idiopathic, where the cause is not known. It is useful in the management of mild to moderate symptoms of the Parkinsonism. The main action is centrally action is there, so it is expected that they should cause minimal peripheral action. Because all peripheral actions can be adverse effect, it is comparatively cheaper and better tolerated than L-Dopa, but still it is not used. The side effects are dry mouth, constipation, drowsiness. Then other drugs are like antihistaminics. Actually histamine does not have any role into it, but this drug like orphanadrine and promethazine, they are having additional activity as antimuscarinic agents, and because of that antimuscarinic action, they are acting like drugs. So there is no role of histamine into it. Example of this is promethazine, that will decrease the tremor, rigidity, and cyalloria. Cyalloria means the salivation, excessive salivation. We have seen this drug-induced Parkinsonism earlier. We have seen various drugs which are causing Parkinsonism. During introduction, their role, example, which are having maximum impact is haloperidol, phenothiazine, which are having highly potent D2 blocking activity. They are responsible for that, and they causes drug-induced Parkinsonism, to what normally we call it as extrapyramidal syndrome. Then next is the reserpine. It is the drug, we call it as a dopamine depleting agent. Again, mechanism is same what we have seen during adrenergic or ANS system. Then metoclopramide is the drug that is which can cross the blood-brain barrier, and it can cross. Metoclopramide is a popular anti-emetic drug. All these anti-emetic also acting on D2 receptor, but it is expected that they should act peripherally, and when they crosses blood-brain barrier and they act on the CNS, they will cause it. Then this is the industrial poison, that is MPTP, that is 1-methyl-4-phenyl 1,2,3,6 tetrahydropyridine is the chemical, and it is metabolized by MAO, which produces neurotoxin, and this neurotoxin will cause destruction of the dopaminergic neurons. Then oxidative stress, earlier we have discussed it so many times that dopamine itself gets metabolized by the enzymes, particularly MAO enzymes, and this MAO enzyme will cause dopamine plus oxygen plus water will convert into dopa, that is dopa carboxylated, plus hydrogen peroxide, that is H2O2, and H2O2 will be oxidized more to make the free radicals. These free radicals they are very toxic. They can react with the many and they can cause damage. So they will cause degeneration of dopaminergic neuron, which is one of the basic reason behind the Parkinsonism. So these are the various questions which can be there. That is why levodopa is combined with carbidopa, why promethazine or anticholinergic agents are used in the drug-induced Parkinsonism. These are various questions people can ask. The other treatment, other drug we shall or other disease we shall see in next time, that is Alzheimer or any other disease which you feel. You go through this. If you have any difficulties, you can ask, and we shall start all this again. If you have any difficulties, you can ask anytime. So take care and be safe. बोल. हां लेक्चर सुरू म्हणून तुला मेसेज केला त्याने. मेसेज नाही मिळाला तुला? काय म्हणतोस? काय खास? बरं बरं बरं. अच्छा, नाही चांगलं चांगलं चांगलं. झालं ना, झालं लेक्चर संपवलं. तुला म्हणून तर तुझ्याशी बोलणं सुरूच केलं, नाही तर तोपर्यंत बोललोच नव्हतं तुझ्याशी. दोन सेकंद फक्त सेव्ह कर. 2 ते 3 लेक्चर असतं माझं. आज तुला नेमकं लेट झालं. दुसरा विद्यार्थी आला तर त्याच्याशी चर्चा चालू होती काय चाललं, काय म्हणतं तुझं दुकान व्यवस्थित सुरू? हो, इथं एक रोडचं टेंडरचं काम चालू आहे MIDC. अच्छा, थोडंसं स्टँडर्ड मेंटेन नाही ठेवलेलं, त्याच्यामुळे तक्रार करायला आली होती मागे. अच्छा, त्यांची मित्र आहेत शिवणकर सर. हो, त्यांच्याकडे सगळं सरांना भेटले. नाही नाही, चांगलं चांगलं. काय झालं सर तुमचं? बस सुरू आहे बाबा, तब्येत वगैरे चांगलं मस्त. काय असं झालं तुला कोरोनाच्या काळामध्ये व्यवस्थित सगळं? हो, कोरोनाच्या काळात सेल जास्त झालं सगळं मास्क वगैरे, सॅनिटायझर्स वगैरे. हो, ते जास्त झालं. पण आता काय नाहीच्याच बरोबर आहे सगळं ना. आता काय सगळं काळजी विसरलं सगळं, आता काय काळजी.